Hypersensitivity pneumonitis, or HP, is a form of interstitial lung disease that develops when vulnerable hosts are recurrently exposed to inhaled pathogens. Catching it early is critical. Timely diagnosis allows clinicians to immediately remove the inciting exposure and begin prompt treatment, a sequence that directly dictates the patient's long-term prognosis. For years, clinicians classified HP based on a rigid timeline, sorting patients into acute, subacute, and chronic categories based on the duration of their symptoms. That approach is now obsolete. The latest clinical guidelines from both the ATS, JRS, ALAT Consortium, and the American College of Chest Physicians, or ACCP, have abandoned temporal categories entirely. Instead, the new classification systems prioritize morphology. They separate patients by the presence or absence of fibrosis, placing heavy weight on histological findings and high-resolution computed tomography, or HRCT, a technique providing highly detailed cross-sectional images of the lung architecture. Both society guidelines now sort HRCT findings into 3 standardized patterns: typical HP, compatible HP, and indeterminate HP. The naming conventions are identical. However, the specific step-by-step logic each society uses to sort a patient's scan into one of these 3 diagnostic buckets creates significant friction between the 2 frameworks. Researchers at the University of Chicago quantified this friction. They conducted a retrospective review of 297 patients from a specialized interstitial lung disease registry. They used multidisciplinary discussion, a collaborative panel of pulmonologists, radiologists, and pathologists, as the reference standard for the true diagnosis. Within this cohort, 67% of the patients were confirmed to have HP. The remaining patients served as standardized controls, carrying diagnoses of connective tissue disease ILD and idiopathic pulmonary fibrosis. When independent radiologists applied both the ATS and ACCP imaging criteria to the exact same cohort, the 2 sets of guidelines disagreed on the final diagnosis 21% of the time. The vast majority of these disagreements occurred in the high-confidence groups, specifically when the guidelines clashed over whether a scan should be labeled typical or merely compatible. The inter-observer agreement between the expert radiologists reading the scans was exceptionally high, hovering between 96 and 97%. Radiologists saw the same physical features. The guidelines simply interpreted those features differently. The data suggests that the 2 medical societies constructed their frameworks to prioritize different statistical outcomes, one built to capture as many cases as possible, the other built to exclude look-alike diseases. This raises an immediate clinical question. If 2 experts agree, but the guidelines disagree, which guideline should a clinician trust? To understand the 21% discordance, we must look at how the ACCP analyzes a scan. The ACCP criteria are inherently more lenient regarding spatial distribution, leading to a higher volume of typical HP diagnoses. This is an inspiratory CT scan of a 76-year-old woman. We can identify lower lung predominant reticulation, along with traction bronchiectasis. When we switch to the expiratory scan, we confirm the presence of small airway disease, visible as clear air trapping in the highlighted zone. Under ACCP guidelines, this patient qualifies for a high-confidence typical HP diagnosis. Because the ACCP allows a typical diagnosis based on minimal criteria, even relying solely on diffuse centrilobular nodularity, it achieves an overall sensitivity of 74. The ATS framework takes the opposite approach. It acts as a strict morphological gatekeeper. For a scan to reach a typical HP diagnosis under ATS logic, the abnormalities must demonstrate a specific spatial pattern, predominant or relative basilar sparing. This means the extreme lower bases of the lungs remain relatively clear. This is a CT scan of a 28-year-old man. In the axial view, we identify prominent ground glass opacity and traction bronchiectasis, but the sagittal view reveals a lack of basilar sparing. The inflammation extends all the way down into the posterior basilar segments. Because of this heavy lower lobe involvement, the ATS logic prohibits a typical diagnosis, forcing a downgrade to indeterminate HP, even though physical features are present. Look back at the data. This rigid spatial requirement results in a measurable statistical trade-off. By filtering out scans that lack classical distribution, the ATS achieves a specificity of 95%, compared to ACCP's 89%. The ATS framework will miss more true cases of HP, but the cases that survive its filtering process are extremely likely to be correct. The mechanical trade-off is clear. ATS guidelines accept a lower capture rate in exchange for the high confidence exclusion of lookalike diseases through rigid spatial distribution rules. Which trade-off, sensitivity or specificity, is more accurate in a real-world clinic? Diagnostic accuracy is subject to prevalence dependency. Performance metrics shift based on the underlying concentration of the disease in the scanned population. This visualization maps a low prevalence environment. At 10% prevalence, it represents the statistical reality of many U.S. interstitial lung disease centers. In this 10% environment, ATS classification outperforms ACCP, returning a total diagnostic accuracy of 92.3% against ACCP's 87.6%. The gap is most evident in the positive predictive value, or PPV. PPV measures the probability that a positive test result actually means the disease is present. The ATS achieves a PPV of 60.7%, while the ACCP reaches only 42.9%. When a disease is rare, the statistical danger is a false positive. The strict specificity of the ATS guidelines prevents clinicians from overdiagnosing HP. Meanwhile, both guidelines generate a high negative predictive value, or NPV. NPV is the probability that a negative test result correctly identifies a patient as disease-free. For the average clinic operating in a low-prevalence region, the stricter ATS framework is the mathematically superior choice for diagnostic accuracy. Now shift the geographical context. In specialized ILD registries in India, regional exposure to environmental antigens can drive the prevalence of HP to exceed 47%. As the disease becomes more common, the performance metrics invert. At 50% prevalence, the broader ACCP classification becomes more accurate, delivering a score of 81.7% against the ATS's 79.7%. The ACCP also takes the lead in negative predictive value, scoring 77.7% compared to 72.6% for the ATS. In a high prevalence zone, the priority is not missing a case. The sensitivity of the ACCP framework allows it to rule out HP with higher confidence. This is the prevalence paradox. The guideline that was mathematically inferior for a clinic in Chicago becomes the superior tool for a clinic in Mumbai. The 21% discordance rate underscores that diagnostic performance is context-specific. Clinicians in low-prevalence areas should lean on the ATS, JRS, ALH criteria when high specificity is needed to avoid false positives. Conversely, the ACCP criteria are better suited for high-prevalence areas where high sensitivity ensures no cases are missed. While these guidelines help standardize recognition, they are designed to be interpreted within a multidisciplinary discussion. The disagreement between these two major frameworks represents two different institutional philosophies towards statistical risk. The most accurate radiologist is the one who chooses their diagnostic framework based on the epidemiological reality of the population they serve.